Welcome to everyone. I'm Kristen Huntley from the NIDA Center for Clinical Trials Network. This is the second of 3 webinars on measurement-based care for opioid use disorders. Today's presentation is titled A Practical Guide to Using Brief Addiction Monitor Data in the VA. And I'd like to welcome our 2 presenters, Dominick DePhilippis and Eric Hawkins. Dr. DePhilippis is the Education Coordinator for the Center of Excellence in Substance Abuse Treatment and Education at the Philadelphia Veterans Affairs Medical Center. This is one of 2 national VA centers devoted to improving the quality of care and clinical outcomes of veterans with substance use conditions. Dom is also a clinical associate in the Department of Psychiatry at the University of Pennsylvania's Perelman School of Medicine. His areas of professional interest include the dissemination and implementation of measurement-based care and evidence-based treatments in specialty care settings for patients with substance use disorders. Our second speaker today is Dr. Eric Hawkins. He's an investigator with Health Services Research and Development, Seattle Center of Innovation for Veteran-Centered and Value-Driven Care, and is the Associate Director of the Seattle Center of Excellence in Substance Abuse Treatment and Education. Dr. Hawkins is also an Associate Professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington, and is a licensed clinical psychologist in Washington State. His primary research interests include evaluating and improving behavioral health and substance use outcomes of veterans with alcohol and/or drug misuse conditions. We welcome both of you, and without further ado, I will ask Dr. DePhilippis to begin.
Excellent. Thank you so much, Kristen. And first, I'd like to start off on behalf of really our entire body of colleagues in the CESATE, certainly Eric and myself, to thank you, Kristen, certainly Betty Ty and your colleagues at NIDA, the colleagues at EMIS, and Tracy Williams and Ron Dobbins for doing all this coordinating. It's really a delight to be able to have this opportunity to speak about the Brief Addiction Monitor to our larger body of colleagues outside of VA. So this is a wonderful opportunity, and we're very, very appreciative of it. So without further ado, we'll get started. So our agenda today is both Eric and myself will be discussing what the BAM is, its development and features, its content, how the BAM is scored, and then we'll get into the specifics of how the BAM is used clinically, how it's integrated into clinical sessions, encounters, how BAM data can be integrated into treatment planning and adaptive treatment efforts. Then we'll talk more broadly about using aggregated BAM data for program evaluative work, both in the VA and of course outside the VA. And then Eric will take the lead in discussing the implementation of the BAM in VA, looking at both the implementation history and then some data, nationally aggregated data that we have collected nationally where the BAM is being administered in VA subspecialty care setting. When we reach that break point between the programmatic use of the BAM and the BAM in VA, we'll pause for some questions, and then we'll, of course, take some questions at the conclusion of the presentation. Okay, so to begin, what is the BAM? And again, to give you some historical context, the development of the BAM was really prompted originally by VA's need to assess patient outcomes in a valid and efficient manner. And that was prompted to a large degree by the VA's experience in trying to implement the Addiction Severity Index in the mid to late 90s. And the Addiction Severity Index, of course, being an instrument with an excellent psychometric standing and data to support its reliability and validity. At the same time, there was some concern among clinicians about the administrative time it took to collect ASI data, as well as the ability to readily integrate ASI data into adaptive treatment planning efforts and motivational enhancement efforts in session with veterans in subspecialty care. In addition, the BAM's development was prompted by a desire to have an efficient system to monitor progress, to really get into the nuts and bolts of measurement-based care, to have a support tool that can inform patient progress in the measurement-based care effort, so that both, again, motivational enhancement efforts and modifications to treatment, adaptive treatment efforts could be informed by data, repeated assessments yielding data over time. And the third interest in development of the BAM was not to be pathology specific. So certainly an emphasis on moving beyond the exclusive attention to pathology, and including, of course, measurements of substance consumption and relapse risk behaviors, but also recovery-oriented behaviors, known in BAM parlance, if you will, as protective factors. And in the development of the BAM, we were able to establish, that is, the VA in collaboration with our colleagues at the Treatment Research Group in Philadelphia, developed indeed a brief measure whose modal time of administration is 5 minutes, and that can be administered both as a clinical interview, but also as a patient self-report paper-pencil instrument. It is indeed multidimensional, having 3 domains. Again, the substance consumption or use domain, the risk factors, that is risk factors for worsening addiction severity or that would set the stage for relapse, and also that third protective factors domain. But there is no singular summary score that has been validated for the BAM thus far. The content of the BAM was accrued and ultimately went through an item analysis after having been gleaned from the extant literature, published literature on factors or variables that had a reliable association with recovery and relapse. And again, the goal was to have this, the BAM content and its data be readily integrated into treatment planning. I'll get into that point in more detail in a moment. And then finally, the BAM content, or more specifically, the responses to the BAM, come in the form of both categorical and continuous responses to items among the 17. Getting into the specifics about the 3 domains and the items, again, the substance use or consumption domain is essentially 3 primary items that examine or ask about the respondent's alcohol use in the past 30 days, their frequency of heavy alcohol use using the NIAAA definition of 5 or more drinks for a male, 4 or more drinks for a female, and then any illicit or misused prescription drug misuse. The risk factors include 6 items: the degree to which the respondent is bothered by craving, any sleep problems, mood disturbances, exposure to risky situations that they've encountered, any concern with interpersonal discord in their family and social network, and difficulties with their physical health status. In terms of the protective factors, again, 6 items comprise the protective factor domain. They include the confidence to be abstinent over the next 30 days. That's one of the only prospective items in the BAM. The rest are retrospective, examining the past 30 days. But the self-efficacy item asks the respondent about their confidence to be abstinent from substances over the next 30 days. Their involvement in self-help, the degree to which their religious or spiritual beliefs contribute to their recovery. Their involvement in gainful activities, whether or not they have sufficient legal income to support basic necessities in life, and the extent to which they are receiving social support for their recovery from friends and family. In terms of the scoring, what we really emphasize is to end users is that each BAM item be considered a score in and of itself, ranging in value from 0 to 30, and on which change over time can be evaluated. But in addition to the items, there are also scores associated with the 3 domains: use, risk, and protective. And we include the simple formulas for each of those. In the case of all the scores, remember the items themselves range in value from 0 to 30, and their sum leads to the ranges of the scores for use being 0 to 90, for risk being 0 to 180, and for protective factors being 0 to 180 as well. In terms of how a treatment provider might, generally speaking, examine the scores vis-a-vis the patient's trajectory and care, well, the general goal would be to maximize the protective factor score, minimize or zero out the risk score so that that ratio of protected to risk is maximized, with the ultimate goal of having a use score of 0, which would indicate abstinence from substances. Now, that said, we do not recommend primary attention among end users be paid to the factor scores, the 3 scores: use, risk, and protected, but instead that the attention be paid to the items, because primarily they have the greatest implications for treatment planning, because they speak to specific symptoms and specific behaviors that the patient is engaging in that either raise or lower their risk or raise or lower their protective behaviors. But additional psychometric evaluation of those scores is indicated before they're used extensively in clinical decision making. Okay, so that brings us to the next issue, which is how do we use the BAM clinically in individual or group clinical encounters? And what we would suggest is that that BAM sessions, what we might describe as BAM sessions, be integrated into group contacts and or individual therapy encounters with patients. That the actual discussion of the content and its implications for adaptive treatment, for evaluating progress over time, be the focus of either the group process in therapy or the individual process in an individual session of psychotherapy. And how that might unfold procedurally is the BAM would be completed prior to that encounter, either same day prior or perhaps a week prior. Of course, we wouldn't want the interval between data collection and the sharing of data to be too lengthy. Obviously, that would incur the possibility or likelihood of change over time. That data that is collected would be entered into, for example, Excel-based scoring templates that we develop, which can auto-calculate scores and auto-populate with graphs of BAM data. That data, those graphic representations of the data would be shared with the patient at the subsequent session or your same-day session if the data were collected earlier in the day. And then that discussion, as I mentioned, either in the group or in the individual session would ensue that would consider what the data's implications are for treatment planning, for what the patient's needs are, how their resources can be marshaled in the interest of reducing their risk or augmenting their protective factors, again with the goal of sustaining or initiating and sustaining abstinence. And then also BAM data can generate some clinical hypotheses that subsequent administrations of the BAM could put to test. Now, I want to demonstrate over the next several graphs, and Eric, I apologize, I didn't advise you. If at any point, of course, feel free to chime in. Let me pause and just give my colleague Eric an opportunity to chime in with his thoughts on what we discussed thus far.
You're doing great, Dom. I don't have anything to add.
Appreciate that. All right, so the next slides really are mocked up to indicate how BAM data might be used by an end user for testing clinical hypotheses or the effectiveness of a change to the treatment plan. For example, the slides I'll be showing you momentarily presume a hypothesized change to the pharmacotherapeutic regimen of the patient to manage their sleep disturbances that we hypothesized were being self-medicated by alcohol misuse. But let's first look at that hypothesis between alcohol use and self-help involvement. So, for example, using our Excel scoring template, we might notice over the first 2 administrations of the BAM, the intake administration and the first follow-up, that our patient is indeed engaging in high levels of alcohol use, and of that alcohol use, the bulk of it is at the excessive or heavy or risky drinking level, again using the NIAAA definition of such. At the same time, we might notice in a graph of the patient's self-help meeting attendance that their self-help involvement is rather minimal and actually has declined slightly since their admission to the program. Well, one possible hypothesis would be to share with the patient in terms of generating a treatment plan change. Perhaps 12-step facilitation might be introduced to augment self-help meeting attendance with the to test the clinical hypothesis that if we indeed augment that service, we might see an effect on the patient's alcohol use. And how that a confirmed hypothesis might look would potentially look as this graph does, where we introduce 12-step facilitation, say, after the first follow-up, and we notice an augmentation of the patient's frequency of attending self-help and a correlational decline in their alcohol and excessive alcohol use. So we'd know we'd be on the right track, if you will, in terms of that adaptive change to their treatment plan. Again, to illustrate a pharmacotherapeutic example of this clinical hypothesis testing, we might notice, for example, that a patient's alcohol use and their sleep problems seem to be positively correlated with each other, where we're seeing high levels of alcohol use and high levels of sleep disturbances in the patient at the first and second administrations of the BAM. We may, either through referral to a prescriber or among prescribers, say, introduce prazosin to address the sleep disturbances, particularly if there was evidence to suggest there was nightmare experiences that were disturbing sleep. And if indeed we were on the right track clinically, we might see this type of data ensue following the change to the treatment plan. For example, the sleep disturbances declining, and then correlationally the alcohol and excessive or heavy alcohol use declining simultaneously. Okay, in terms of treatment planning for the BAM, let me start by saying that we recently, that is the CESATE, recently examined the 2016 VA DOD clinical practice guidelines and updated treatment planning content that we developed for the BAM to be aligned with the latest recommendations in those VA DOD 2016 clinical practice guidelines, such that an end user, having available to him or her a library of problem statements, goal statements, objective statements, and even suggested interventions, can craft a treatment plan in collaboration with the patient based on that patient's array of BAM data. So rather than treatment planning necessarily including being a creative writing exercise to maximize the individualization of treatment planning, in this case, the individualization would be accomplished by the unique array of data that patient has provided us through their completion of the BAM, and then we, together with the patient, could select appropriate problem, goal, outcome, and intervention statements from this library of statements that, again, is aligned with the clinical practice guidelines to craft a treatment plan that is tailored or customized to that patient's unique array of risks, unique array of resources and strengths. And how that BAM data can be used is specifically to determine patient strengths, to indicate the presence of a problem. Certain BAM items can be evidentiary in establishing the presence of a problem to be addressed in the BAM. Certainly, ongoing data collected from the patient can provide evidence of achievement of goals by measuring the progress on the objectives that were written based on earlier BAM data. And then we could, again, select and measure the effectiveness of interventions for specific deficiencies in the patient's lifestyle, akin to the graphs I was showing you a moment ago, comparing, for example, self-help involvement and alcohol misuse. Now, that PGOI content, those problems, goals, objectives, and intervention statements, again, are aligned with the 2016 clinical practice guidelines and available from the CESATE for any end users to be deployed in their use of the BAM clinically. And how a treatment plan developed based on the BAM might look is this, and I know it's a busy slide, but just to give you a sense of how BAM data can be integrated both into the establishment of a problem or evidence of a problem using the BAM items as problem indicators, as evidence of strength of the patient. Then based on that, we might establish with the patient his goal in this case of leading a sober lifestyle. The first objective might be BAM informed in the form of, by such and such a date, our patient John Doe will demonstrate a 50% reduction in his risk score from the baseline BAM assessment conducted on such and such a date. In terms of our contribution as the provider to the treatment plan process, in terms of the interventions we would provide the patient, one intervention might be from such and such a date to such and such a date. Dr. DePhilippis will provide John Doe with training on craving management skills during his weekly individual therapy sessions, and what that particular intervention is seeking to do is reduce the risk associated with BAM item 8, which happens to be the craving item. And there might be an additional intervention on such and such a date. Dr. Hawkins will provide John with a list of 12 step meetings within walking distance, defined as within a quarter mile of John's home. And in that case, that intervention is seeking to augment the protective factors in the form of self-help involvement, which is item 10 on the BAM. Okay, so that's the individual measurement-based care application of BAM data. Again, sharing the data with the patient for clinical hypothesis testing, to generate motivational enhancement opportunities, and of course to inform adaptive treatment efforts. Now, more broadly at the programmatic level, BAM data can also be aggregated and used for program evaluation purposes. For example, BAM data could provide information to address the question about whether or not the sub-treatment program is reducing substance consumption. We could aggregate the BAM data and see if indeed the items 4, 5, and 6, the alcohol, heavy alcohol, and illicit substance use data is showing a decline over time. And if not, we may, as a program, decide to augment certain services to address that lack of effect. We also might specifically look at how data in our patient population or the patients presenting for care in our clinic has changed since we've made a program-wide change to our service provisions. For example, as a program, we may have decided to augment the availability of alcohol use disorder pharmacotherapy. We're making a concerted effort to get naltrexone and ecamprosate and topiramate out to the patients, or at least offer to them. We might be able to tell, we can be able to test whether or not that effort has had an effect on craving pre-post. And then we can even use the BAM data for clinical supervisory work with among program managers with their subordinate staff. For example, BAM data could help address the question about whether treatment plans are individualized. Are they adapted to the patient's unique, changing, dynamic constellation of problems and strengths as reflected by their BAM data? And then are the BAMs being administered as your program stipulates? For example, are the providers administering the BAM, if the program rule is an assessment every 30 days, are the BAMs being administered every 30 days to each patient? And then supervision can be tailored towards either making changes, corrective changes to the provision of care, or, of course, reinforcing, praising adherence to the program stipulation. The next set of graphs, including this one, are actually based on VA data from different programs in the VA that we have extracted aggregated BAM data, and we present them to illustrate how aggregated BAM data over time can give a sense of the program's effect vis-a-vis BAM-related outcomes. So, for example, what this graph is indicating is that over a series of 6 BAMs with an interval between BAMs of, on average, 30 to 60 days, we indeed, or at least this clinic is indeed seeing a trend in a decline in their patients' risk factors, sort of a plateau, an increase and a bit of a plateauing of protective factors, and then an increase later, and then most importantly, a steady decline in substance consumption or substance use, ultimately zeroing out by the final BAM administration. We could also look at the aggregated substance use and craving items, for example, looking at percentages of patients reporting a particular behavior. For example, in the very first set of bar graphs in this histogram, we noticed that at intake, or at the first BAM, 81% of our patients were reporting alcohol use in the past 30 days. By the 6th BAM, that has reached a percentage of 0. Likewise with heavy alcohol use and any drug use. And we could see even a change in the number of patients reporting any craving in the past 30 days and any substance misuse defined as either alcohol or drug use in the past 30 days. And again, this is actual VA data. Again, aggregating the data on individual risk factors, the health, the sleep, the mood disturbance or depression item, the craving item, the risky situations, exposure to use the 12-step parlance, people, places, and things, and then also the degree of being bothered by interpersonal conflict with one's social and familial networks. And again, we could look at change over time on these individual risk factors as a program. So, for example, if we notice that as a program we were having a good impact on health, sleep, and mood, and exposure to risky situations and social problems, but although this graph doesn't indicate it, but if we notice that we weren't necessarily impacting craving, we might, for example, as a program, decide to augment our anti-craving services, pharmacotherapies, CBT-related services to assist our patients with coping with craving. Likewise, we could look at protective factors over time. And then we could even drill down in terms of looking at how craving has changed, even if, indeed, we haven't necessarily changed the overall percentage of patients that are reporting craving in the past 30 days. We certainly could drill down and find, in this case, that even though patients are reporting craving, the degree to which their craving is bothersome to them has changed significantly from time 1 to time 2, where, for example, at the first assessment, only 12% of patients were not at all bothered by their craving. We've increased that to 26% at the follow-up. And again, conversely, whereas 25% of the patients at the first BAM were experiencing extreme bothersome reports of their craving, that's reduced to 2% over time. All right, Eric, take it away.
All right, thanks, Dom. So for the remainder of these slides, I'm going to sort of ask you to take more of a 10,000-foot level perspective to sort of show you some of the aggregate national data using the BAM, and then also provide just sort of a brief history of implementing the BAM in the VA. So the BAM was initially implemented in 2012. It was across the VAs throughout the nation, primarily the VA specialty care SUD programs. And these programs were encouraged but not required to administer the BAM at baseline and at follow-up. And as Dom mentioned sort of earlier, the BAM was designed to facilitate measurement-based care for substance use disorders. And this was sort of in anticipation of more focused efforts to implement measurement-based care in the VA. And in May of 2016, the VA launched the Measurement-Based Care in Mental Health Initiative. And currently that's focused mostly on sort of piloting the use of the BAM, as well as several other measures like the PHQ-9 and PCL checklist in the VA. So you can ignore the verbiage on this slide. The primary reason we're showing it was really just to give you an indication of just how often the BAM is administered in the VA. And so you can see here in 2012, when the BAM was initially implemented, it was just a little less than 30,000 administrations. And then for the 3 subsequent years, and I don't have 2016 data on here, but if you were to look at it, it'd be roughly the same. But over 70,000 administrations of the BAM occur annually. So now I'm just going to provide kind of a closer look at national BAM data, and that's primarily with respect to administrations at intake and follow-up. Before I do that, I'm going to just orient you to the slide a bit. So the left axis indicates the number of patients with new treatment episodes. And on the right axis, you'll see that it's percent of intakes with completed BAMs. And then at the bottom is essentially the timing of when the BAMs were administered, and it's by quarter and then within fiscal year. So you can see with the line that sort of traverses across these bars, that essentially about 35% of patients who start a new treatment episode in the VA, new addiction treatment episode in the VA, complete a BAM at baseline or at the start of treatment. Just orient you a little bit to the slide as well. So on the left axis, you'll see that the number of patients with an intake BAM. So we're sort of borrowing a subset of the cohort that was on the prior slide. And then on the right is the percent of patients with an intake BAM who also have completed a follow-up BAM. And just to give you a little bit of information or sort of definition on how we define follow-up, we've essentially asked the sites, programs throughout the VA, to administer the BAM at baseline and then at follow-up, which in our case is defined as somewhere between 30 and 60 days after the initial BAM administration. And so you can see from here that about 3 in 10 patients who start treatment and are administered the BAM at baseline and are still in treatment sometime during that 30 and 60 days are administered a follow-up BAM. And as you can see here, the rates too are quite similar across the 4 years that we're looking at. About 104 of the 129 medical centers with specialty substance use disorder care programs are using the BAM, or at least administering the BAM at baseline, somewhat routinely. I use that somewhat loosely because our definition is a little broad. You had to have at least been administering the BAM to at least 10% of the patients, patients with new treatment episodes. So now just to provide more sort of aggregate data, in some cases it's looking at some of the data that Dom already showed, but again, sort of at a national level, and it's with respect to substance use at intake and follow-up. So what this slide is essentially indicating is that among patients with an alcohol use disorder, about 30%, so 3 in 10, are abstinent from alcohol at intake or when they start treatment. And about 80%, so between 78 and 80%, are abstinent from alcohol at follow-up. And the numbers that you see that on the bars are essentially just sort of showing you what the raw percent change in abstinence is. And on this slide, it's essentially indicating that among patients with a drug use disorder, about 4 in 10 are abstinent from drugs at baseline, so at the start of the treatment episode. And that abstinence rate rises up to a little bit above 80 to 85% at follow-up. And this slide sort of providing a glimpse of what it looks like among those with both alcohol and a drug use disorder. So at least in our cohort, I mean, arguably some of the more folks with more severe substance use disorders. So among those with both alcohol and a drug use disorder, about 2 in 10 are abstinent from both alcohol and drugs at intake. And then at follow-up, that rate rises to about 80%. And you can see here, this is sort of where our largest percent changes in abstinence occur. So this is the last slide, and I'm really there's not a whole lot to show you here. It's to highlight that one of the advantages to having a sort of large electronic health record that archives data quite well is that you have some pretty potent opportunities to do interesting either research using the BAM or, as sort of Dom alluded to earlier, quality improvement work with the BAM. So we can link BAM data to other VA demographic, clinical, and utilization measures, and I've sort of given you an indication here of some of the demographic variables that we have available. So gender, age, marital status, race, service connection disabilities, and folks who have some type of disability that was due to their service in the military, and then ethnicity. And then as far as clinical diagnoses are concerned, I sort of highlighted substance use and mental health diagnoses. TBI diagnoses are one of those that might be interesting, particularly for a subset of our population. But there's also scores and scores of medical related diagnoses that are available in our corporate data warehouse. And then inpatient admissions and outpatient utilization. And with regards to inpatient admissions, that can include actually admissions that are related to, for example, sort of management of alcohol withdrawal. But that also includes psychiatric admissions as well as medical admissions. And then outpatient utilization really sort of crosses the gamut of the services that are provided to the VA. So they might be SED specialty care, but they can also be mental health, probably the most common primary care visits. We also have access to several sort of pharmacotherapies, and again, that would include those that might be relevant to the provision of alcohol and drug use disorder treatment, as well as mental health treatment, but also any types of pharmacotherapies that are treating whatever medical condition veterans might have. And then lastly, we also have access to death, and more recently, sort of cause of death. So the opportunities are pretty abundant. There's a lot to be done. We have done, honestly, to this point, very little with the BAM. And we're just sort of starting to look at some of these things. And then lastly, if we can open it up to questions, and that would be both for these last, 10 slides, but as well as any questions that you might have with regards to what Dom presented earlier.
Eric and Dom, thank you for the terrific presentation. This is very important work and sounds like there's potential to significantly improve quality of care. And I see the inclusion or looking at protective and risk factors as a strength to this particular measure. And the ability to link to EHR data is very exciting. Let's open it up to questions.
From Gavin Bart, the BAM uses validated items for recovery. What definitions of recovery and relapse were used in this validation?
Yeah, good question. We did not establish a rubric or an operational definition of recovery. Instead, looked at the extant literature on variables that were replicated in their association with outcomes of recovery defined in the extant literature. So, for example, from ongoing substance misuse to abstinence among patients in subspecialty care. So there wasn't it wasn't quite a process that one might engage in, say, a meta-analysis where you establish specific rules for inclusion of a published report in your analysis, but we were just looking instead for the variables that were repeatedly associated with recovery as defined, again, with some variability in the extant literature for substance misuse. And again, broadly speaking, moving from misuse to abstinence.
And Gavin continues. This is about the BAM scoring. Sleep and mood are often very collinear. How has this been addressed in BAM scoring?
Yeah, great question. I completely agree. The structure of the scores currently consider the two items orthogonal. So they both contribute an equal portion to the overall risk score. But at an individual level or an ipsative evaluation of the patient against his or her own baseline, one might identify that those two variables do indeed co-vary consistently, and might address both by intervening with one, presumably with the goal of affecting both variables. However, at the same time, at the individual patient level, we might not necessarily see that shared variance between those two items, and the BAM data collected over time would provide evidence of that more orthogonal relationship between those two symptoms.
And are there differences in treatment outcome between clinics using BAM and those not using BAM?
I can take that question.
Now, that's a good question. Yeah, please.
It is a good question, and we're just starting to sort of entertain some of these, these ideas and analyses. To date, we haven't done that yet. The biggest challenge is trying to find an objective sort of outcome to look at. We do have a few, and the most common that come to my mind are mortality, which I mentioned earlier, and then certainly acute use of services, so emergency department visits and inpatient services, use of inpatient services. But we haven't done it yet. It's a great question, though.
Okay, great. So we're going to move on. Thank you, Gavin. If you have any follow-up questions, let us know. Leanne Hu, are there specific BAM results in VA databases with respect to prescription opioid drug use?
Okay, yeah, in terms of opioid, the response to opioid use disorder treatment or opioid misuse, yes, we are capable of, for example, parsing data that is generated by opioid medication-assisted treatment clinics, opioid replacement clinics, for example. Nationally, I don't think we've parsed the data as such, but one could, for example, aggregate the data from patients who are receiving those BAMs in the course of their care for OUD and opioid replacement programs to identify response to treatment in aggregate. And the BAM items, I mentioned the item 6, which looks at illicit substance misuse in general. What I did not mention, but is germane to this question, is that item 7 in the BAM essentially drills down on item 6 by asking the respondent in a series of items ranging from 7A to 7G, what particular substances is the patient misusing that in total comprise their response to item 6, which is overall illicit substance misuse. And one of those items, sub-items in 7 is the patient's misuse of opioids.
Okay, and Leanne had another multi-part question here, so I'll ease through it. Are there results from VA's Collaborative Mental Health Management Enhanced Dashboard regarding 1, patients and clinicians' feedback on the BAM implementation, and 2, coordinations across different treatment team groups, whether primary care, psychiatric, and behavioral treatment groups? And I can read that again if needed.
Please do, but yeah, I think I have a general sense, but please do.
Okay. Again, are there results from VA's Collaborative Mental Health Management Enhanced Dashboard regarding 1, patients and clinicians' feedback on the BAM implementation?
No.
And 2,
okay, thank you.
Okay, got it.
Yeah, I just wasn't sure of the earlier part. Well, actually, the broader measurement-based care and mental health initiative in VA is attempting to gather that very feedback from providers and ultimately from the veterans themselves on the measurement-based care process. The national initiative in VA is an attempt to change the culture of VA to be a measurement-based care-oriented culture in mental health, certainly including but not limited to the treatment of patients with substance use disorders. So in the course of that initiative, one of the sources of feedback that we are evoking from the field is their reports on concerns about implementation of measurement-based care, how veterans are responding to measurement-based care, and barriers and challenges to the implementation of measurement-based care nationally in VA. I could tell you that on a smaller scale, we in the CESATE conducted in 2010 a series of focus groups with veterans who had received multiple BAM assessments as a part of their involvement in measurement-based care. And there was unanimous enthusiasm, approval, and receptivity among the veterans in those focus groups, and it numbered roughly 60 to 70 veterans in total that comprised those focus groups, for having data feedback, especially in the form of graphic representations of their data. So we know that there's a high degree of receptivity to measurement-based care. In terms of the challenges to its implementation, I think that it's not unique certainly to the BAM, but it's basically meeting the challenge of a group of very busy clinicians engaging in what for some is a more novel practice and trying to change their behavior as such. And the initiative's goal is to provide the education, support, and training to make that culture change in VA.
And I think that may have addressed to some extent Kristen Huntley's question, what are some of the barriers to follow-up administrations that clinicians encountered and reported?
Yeah, this is Eric. Those that Dom mentioned, we've had particular challenges around sort of information technology support. And one of the biggest issues is we do not have a way, an efficient way, of identifying when a patient is in that 30 to 60-day window. And so it's really left up to the sites. And Dom might have some ideas about how some of the sites have sort of navigated that. But that's certainly one of the big sort of barriers that we've had. You know, there's a system by which the BAM data is entered into so that it actually goes into the medical record and is stored properly. And it's not by no means has a very appealing interface. It's a little clunky. And the graphs that it generates are not very, at least visually appealing. And I think in part that's why Dom has really sort of facilitated the use of Excel templates and graphs to make them more engaging and appealing to those that use them.
Yeah, I think Eric said it better than I could. That indeed, that is a principal challenge to implementation of measurement-based care is our tech limitations in the VA. But thankfully, that is a VA priority. Certainly, our current secretary, Dr. Shulkin, has made the improvement of VA's IT system a priority. But indeed, our current interface, the mental health assistant, is not the most user-friendly, nor does it produce the most understandable and aesthetically pleasing graphs to be shared with veterans. And indeed, that, as Eric pointed out, was the primary motivator for the development of our use of these Excel templates. Now, even if at some point the VA IT system is improved to a degree where the Excel templates are no longer of value or use in the VA, they certainly, we imagine, will be useful to outside non-VA subspecialty care programs and are free for use by those programs. All the materials, the BAM included, are in the public domain with no licensure or fees for use.
Well, Donna and Eric, I think you covered it well. We don't have any other questions. If anyone would like to reach out to us, please feel free to send an email to ctntraining@ms.com, and I will be sure to get that over to both our speakers, and we'll follow up.
Well, thank you so much, and my comments will be brief. Thank you so much for this opportunity to discuss the BAM. I certainly, and I'm sure I speak for all my colleagues in the CESATE, do not want this to be a one-and-done opportunity. We are available for consultation on use of the BAM. Happy to do teleconferences moving forward, or consult individually with any of the audience members or their colleagues regarding measurement-based care in general, or the BAM in particular. So thank you.
I agree with everything that Dom said. And Tracy, you should feel free to give out at least my email if people have questions that they want to ask at a later point in time. I'd be happy to answer them.
Sounds great. Thank you. Kristen, you've got the last word.
Thanks so much, Tracy. Dom and Eric, thank you again for presenting today on behalf of the NIDA CTN. We really appreciate your time and expertise and sharing the information about this important VA initiative, and we also welcome additional conversation. This is the second of 3 webinars on this topic, so we hope all who have participated today will participate in the next one. Thanks so much.